Hi, I'd like to introduce our next speaker, Dr. Maria Yielamas, who is an assistant professor of medicine at Harvard Medical School and a faculty member in the Division of Endocrinology, Diabetes, and Hypertension in the Department of Brigham and Women's Hospital in Medicine. She's going to be speaking today on evaluation of the patient with menstrual irregularities, a common problem that we see. Thank you so much for joining us, Dr. Yielamas.
Thank you so much. So I'm going to go ahead and get started. And before we go to our cases, I thought it would be good for us to review a little bit about the female hypothalamic pituitary gonadal axis and just remember a little bit of just normal physiology. And I think whenever we do think of menstrual disorders or irregularities, which are quite common in practice, especially in primary care practice, to see these, it's important to go back to the basics. And just as a reminder, at the level of the hypothalamus, GnRH, gonadotropin-releasing hormone, is released in a pulsatile fashion, and this can vary in terms of timing depending on where you are in the menstrual cycle. This leads to goes to the pituitary gland, and then you get luteinizing hormone and follicle-stimulating hormone release, which in the ovary produces estrogen release, progesterone, some proteins called inhibins, and most of the time you get negative feedback, except in the middle of the cycle where it's a feed forward. And I'm going to show this on the next slide. And when we think about patients with menstrual disorders, we want to remember that there can be a problem at the level of the hypothalamus, the pituitary, or the level of the ovary or uterus. So just as to remember a little bit about the normal menstrual cycle, in this graph, you will see here at the bottom on the x-axis, this is day of ovulation, and this is the menstrual period here. Here in pink, you have luteinizing hormone. In aqua, you have FSH. On the bottom graph, you have estradiol in green and progesterone in yellow. And just to remember, after menses, you start to see a rise in follicle-stimulating hormone, which causes a rise in estrogen. Eventually, you get this LH surge, you can see here in pink, and with that, after the LH surge, you get the rise in progesterone and the fall. And as the progesterone falls, then menses occur. And what's important to remember when we think about the menstrual cycle is that the length is almost always 25 to 35 days. So if someone says that they have a menstrual cycle that's every 20 days or 21 days, almost certainly many of those cycles may be anovulatory. Or if someone has a cycle that is 37 or 40 days, you have to think, is this an anovulatory cycle? What's usually constant is the luteal phase. So after you have the ovulation, this luteal phase is usually constant in most women, anywhere from 12 to 14 days. Why one woman will have a 25-day cycle and why one woman may have a 32-day cycle is because the difference in this follicular phase. So that's important to remember as we move forward. So next we're going to move to our first case. This is a 19-year-old woman who presents to your clinic for evaluation because she had no menses for 8 months. Her menarche was at age 13, and she had regular menses until 8 months ago. About 1 year ago, she increased her aerobic exercise and had a 20-pound weight loss. She's not had any headaches, vision changes, hot flushes, night sweats. She has no history of an eating disorder, and her thyroid review of systems are negative. Her physical exam reveals a BMI of 18. She's normotensive, has a normal pulse. Her skin reveals no terminal hair growth, so no hirsutism, no acne, no alopecia. Her visual fields are full. Her thyroid is normal in size and without nodules. She has no galactorrhea, and her pelvic exam is normal. So the question is, what is her diagnosis, and what labs would you order? I'll give you a couple seconds to think about that. So what she has is amenorrhea, and I just wanted to distinguish a little bit the difference between primary and secondary amenorrhea. Primary amenorrhea is the absence of menses by age 16. Secondary amenorrhea, which is what most of us see in our practices, is absence of menses for a period of 3 months. And when you think of both of these, the pathophysiology considerations are the same for both, but primary amenorrhea has many more anatomical abnormalities or genetic causes in terms of the etiology. And when we think of etiologies of amenorrhea or irregular menses, I'd like to think of 3 major categories. Of course, number 1, 2, and 3, you want to rule out pregnancy if someone has amenorrhea. Number 2, I think about our uterine outflow tract disorders. And third, I think about ovulatory disorders. And the reason I put uterine or outflow tract disorders second is because since we're not gynecologists, we often don't think about this. And this is something that we don't want to forget about in terms of our differential diagnoses. And ovulatory disorders, obviously, we're better versed in and think about more often. So thinking about primary amenorrhea and thinking about the different etiologies, hypothalamic, pituitary, ovarian, uterus outflow tract, or PCOS, we see that ovarian etiologies are the most common at 43%, followed by hypothalamic at 27%, and then uterine outflow tract at 19%. And many of these ovarian etiologies are genetic, things that are chromosomal etiologies, Turner syndrome, and the like. Now, if we compare secondary amenorrhea, we can see that hypothalamic are more common, or the most common at 36%. Second is polycystic ovarian syndrome. And third is a pituitary etiology. And you can see how low in terms of ovarian and uterine outflow tract at 12 and 7%. So that's sort of the difference in terms of causes between primary and secondary. So when we think of the diagnostic evaluation of patients who come in with amenorrhea, I would argue there are probably 4 tests that should absolutely be ordered. One is an HCG to rule out pregnancy. Secondly is an FSH, which is probably our best marker for ovarian insufficiency. Some people may add an estradiol with the FSH. Third is a prolactin level, because even mild elevations in prolactin can cause irregular menses. And fourth is a thyroid, because both hypo and hyperthyroidism can result in menstrual irregularities. So in our patient, there were 4 labs that were done. One was an FSH. The FSH came back normal at 3.2. The prolactin and TSH were normal, and her pregnancy test was negative. Subsequently, she was given a Provera challenge, which was negative for a withdrawal bleed. So my question is, what is her diagnosis? And I'll give you a couple of seconds to think about that. So we know that there is the etiology is at the level of the hypothalamus or pituitary gland. And the reason we know that is when there's a lack of a bleed with a Provera challenge, we know that that means there's a low estrogen state. As we talked about before, when you have low estrogen because of negative feedback, you would expect FSH to be elevated. And the fact that she has an inappropriately normal FSH tells us that she's not able to produce the signal from the hypothalamus or pituitary gland. So I believe probably most of you thought about the etiology, and it is the most common etiology for hypothalamic and pituitary causes, and that is functional hypothalamic amenorrhea. Other causes of hypothalamic or pituitary etiologies include hyperprolactinemia, tumors, genetic etiologies such as Kallmann syndrome, cranial irradiation, pituitary tumors, lymphocytic hypophysitis, pituitary infarction, and empty sella syndrome. But far and away, functional hypothalamic amenorrhea is the most common cause. And it's a very interesting disorder, and I like to think of it in terms of looking at energy, where energy output exceeds energy input. And you can think weight loss can cause this, eating disorders, excessive exercisers. Other etiologies can include stress, either psychological or physical stress, where you have shutdown of the hypothalamic pituitary gonadal axis. And there was this wonderful study done back in 2004 that was the proof of concept that leptin really is the essential signal to really tell the body that there's sufficient energy stores for reproduction. And the study by Corinne Welt, where she showed by given recombinant leptin at physiological levels that she could actually induce LH pulses in women with hypothalamic amenorrhea, showed that this was to be true. And I have two graphs from this paper that I thought really show this well. Here you can see this is a woman with hypothalamic amenorrhea at her baseline, where you can see in white her LH pulses are quite flat, and that you can see here in yellow with leptin, very low levels of leptin. This patient was given recombinant leptin, which you can see here in physiological levels in yellow, and sure enough, her LH pulses came back. And what was wonderful in this paper is that many of these women, probably over half, actually had LH pulses for the first time, and about 30 to 40% actually ovulated and actually had a menstrual period. And what was interesting is that they lost weight with the leptin, but the body was full to think that there's enough energy stores, and they were able to actually grow follicles and actually ovulate many of those follicles. So it really showed that leptin is the key hormone. So there are a couple of management questions that come up with these patients. One is, does this patient need an MRI? And I would argue that most of these patients, if they have a good story, they exercise excessively, they've lost a lot of weight, they do not need an MRI. The patients that I would consider getting an MRI on are the ones with headaches or neurological symptoms, patients that have any elevation in prolactin, even mild, because sometimes even mild elevations in prolactin can mean that there's a large pituitary tumor that's in causing stalk deviation, and that's why the prolactin is elevated, and you don't want to miss that. If the history is unclear, they don't exercise excessively, they have not had a very low-fat diet, they don't have excessive psychological stress, then you do want to get an MRI on those patients. All patients with primary amenorrhea, because there is a significant chance that these patients may have a pituitary or hypothalamic tumor. And then the second question is, do these patients need a bone density, especially because they're in this low estrogen state? And I would argue that most of them do not. However, if they've been amenorrheic for more than 6 months with no estrogen replacement, you may want to consider getting a bone density in these patients. In terms of recovery, oftentimes patients, even when they're in their late teens or 20s, will ask you, what is the chance that I will recover from this? Is this going to be a lifelong illness or not? And this was a very small study, but it did show that if stress and weight loss is the cause of the hypothalamic amenorrhea, when that etiology is removed, so the stress is relieved or the patient gains weight, 100% will recover. If someone has an eating disorder, probably about 60% will recover, and most of this is because an eating disorder tends to be more of a lifelong illness. And if it's idiopathic, that you can't find an etiology, then most of these do not recover. In terms of treatment, weight gain and decreasing exercise are the mainstays. In terms of estrogen replacement, it is now recommended by the Endocrine Society that actually you give hormone replacement therapy around 100 microgram patch equivalent. Although I find that many patients do not want to be on hormone replacement because it does not give them protection against pregnancy, especially as they start to gain weight and they may start ovulating again. They prefer instead just to be on an oral contraceptive and not have to worry about it. But if really you're worried about just protecting bone and seeing whether or not they do start to have menstruation on their own and ovulating on their own, hormone replacement may be the best therapy for that specific group of patients. Calcium and vitamin D are important. I like to really emphasize calcium through the diet to make sure they're getting adequate amounts, and vitamin D, 800 to 1,000 units a day. So now we're going to move on to case 2. It's a rare diagnosis, but has important management implications. So this is a 27-year-old with 3 months of amenorrhea. She's a moderate exerciser, has no eating disorders. She's had a history of insomnia, no hirsutism and mild acne, and she has a history of hypothyroidism on thyroid hormone replacement. She has a family history of early menopause, and her physical exam is unremarkable. She gets those 4 tests that we discussed before. Her FSH is elevated at 56, her TSH and prolactin are normal, and she's a negative pregnancy test. So my question is, what is her diagnosis, and what further evaluation would you do? And I'll give you a couple seconds to think about that. So we know the problem is at the level of the ovary. And the reason we know that is that the FSH is elevated, telling us that there's a low estrogen state. Through negative feedback, FSH is being upregulated and trying to stimulate the ovary to produce more estrogen. So this patient has primary ovarian insufficiency, which previously was known as premature menopause. And this is defined as an elevated FSH in a patient less than 40 years of age. And what's important with this diagnosis is actually getting repeat testing. So if they have amenorrhea, you can repeat the testing at any point in time. If they have irregular menses, you want to make sure that you get the testing done in the follicular phase. You may remember when I showed you the picture of the menstrual cycle and how FSH rises and falls. You want to make sure that you get it in the follicular phase, because you could see an elevated FSH sort of in the right before the ovulation. You want to make sure you don't misinterpret the values. Causes of primary ovarian insufficiency include Turner syndrome, X chromosome deletions, Fragile X premutation, autoimmune etiologies, chemotherapy, radiation therapy, and some rarer genetic causes. In terms of diagnostic tests that are important to consider in these patients, and this is why I present this case, it's important to think about doing a karyotype. And when you think about this, you want to think about which patient you want to do this in. Less than 30 years of age, definitely. Familial cases where you see many families, you definitely want to do that, because there are these Turner's mosaics where they may have some years of menstruating and then actually maybe at age 22, 25, stop having menstrual periods. And some people would argue almost everyone should get a karyotype. But if you really want to be cost effective, less than 30 years of age, familial cases, and also patients with Turner's features, the web neck, the wide carrying angle of the arms, the short stature, those may be other patients you want to consider this in. In terms of Fragile X premutation screen, many of you may know of Fragile X syndrome, which is probably the most common cause of the of delay seen in the pediatric population. We know that mothers or women who are premutation carriers can actually have primary ovarian insufficiency. So this is a population that you want to consider getting that done. Antithyroid and anti-adrenal antibodies are also important because they may help in terms of thinking about autoimmune etiologies. Anti-ovarian antibodies are actually not useful at all. The sensitivity and specificity is quite poor, but if you see TPO antibodies, thyroid peroxidase antibodies that are elevated, or anti-adrenal antibodies against 21-hydroxylase, which is the common mechanism by which you develop ovarian insufficiency. If those are positive, that may make you think a little bit more that this may be an autoimmune etiology. So something to think about. Ovarian biopsies are not helpful in these cases, so should never be done. In terms of treatment, this is another population where you can give hormone replacement therapy, and that's enough to protect the bones. But I would say that psychologically, this is a very tough diagnosis for a patient to get. And as such, oftentimes these are young women in their 20s, and they don't want to be different than their peers. They're in college, grad school, and they do prefer to be on oral contraceptives. So really being careful about what may feel right to them. And just like you would in a woman with menopause, you want to think about calcium intake, make sure they're getting enough through their diet, and also vitamin D supplementation, 800 to 1,000 units a day. So now I'm going to move on to the third case, which is extremely common in practice, and we can talk a little bit about diagnosis and management. This is a 28-year-old woman who presents to your clinic for evaluation of irregular menses, and she describes irregular menses since the age of menarche, which was 14 years of age. She's also had problems with terminal hair growth, with increased hair growth on her upper lip and chin. She has no hot flashes, night sweats, galactorrhea, or positive thyroid review of systems. She's on no meds currently, and she's a family history of type 2 diabetes. Her BMI is 29. She has hirsutism of the upper lip, chin, sides of her face, no acanthosis, and no clitoromegaly. So my first question is, what labs or studies would you order in this patient with this menstrual disorder and evidence of hyperandrogenism? So these are the lab tests I would consider. 1, thyroid, TSH. 2, prolactin, because we know that prolactin can cause irregular menses, amenorrhea, and it also can cause hyperandrogenism symptoms. An FSH, because some women with primary ovarian insufficiency, or if it's later in life, thinking about perimenopause, there can be an androgen burst and cause sort of increased acne, hair growth. So you want to make sure that you're ruling that out. And last, you want to think about hyperandrogenism and how do you assess that. And I would recommend getting a total testosterone. I would not get a free testosterone. Most of the free testosterone assays are quite poor and can over or underestimate. A total testosterone can give you a great sense of what someone's androgen status is. And also things that another one that's fallen out of favor is DHEAS from the adrenal gland. We secrete DHEA, and then that can be sulfated. And the reason why is that it really doesn't add much in terms of the diagnosis, and there could be variability in accuracy of the lab where these assays are performed. So in this patient, she had a TSH, prolactin, FSH, and androgen levels, specifically total testosterone, and all of these were normal. So the question is, what is her diagnosis? And I think most of you are probably thinking of this, polycystic ovarian syndrome, which is extremely common. And also it's a very interesting disorder where there's an interplay between insulin resistance at the level of the adipose tissue and muscle. This insulin resistance can cause disordered LH and FSH secretion. And this in turn can cause, the insulin resistance can cause hyperandrogenism. The hyperandrogenism can cause worsening insulin resistance and also can cause disordered release of our pituitary hormones. So really there's an interplay between all three, and then it becomes sort of a cycle that's hard to break. In terms of epidemiology, it's extremely common, as we have discussed, 5 to 7% of women will have the PCOS as defined by the traditional definition by the NIH. It's probably the most common cause of female infertility, accounting for 50 to 60% of cases. And many do feel it is the most common endocrinopathy in young women. The traditional definition, which many of us may remember, includes irregular periods and hyperandrogenism, either clinical or biochemical. And if you exclude other diseases, you make the diagnosis. And this is the older definition that was used, especially for some of the epidemiology studies. But what I want to focus on is what we use currently as our definition for PCOS. And this is the Rotterdam definition. And we say that you have to have two out of the three of the following. 1 is the irregular menses. 2 is either clinical or biochemical signs of hyperandrogenism. So that means either clinically you have alopecia in a male pattern, you have acne or increased terminal hair growth, or you have an elevated testosterone. And 3 is the polycystic ovary. So all you need is 2 out of these 3. And if you've excluded other etiologies, that's where the TSH comes in, the FSH, the prolactin levels, then you can make the diagnosis. And just looking at 2 out of the 3, that means in many cases, you really don't need to get an ultrasound. You could probably make the diagnosis just through clinical means and laboratory means. I did want to show you that when you do get an ultrasound to help you with a diagnosis and the radiology report says polycystic ovaries, what they're actually seeing or visualizing on ultrasound. And I'd like to thank Judy Adams from the Mass General for lending me these pictures. So on the top is a polycystic ovary, on the bottom is a normal ovary. And what I think you're struck by is how much larger the polycystic ovary is than the normal ovary, and also how the follicles or eggs in the normal ovary are randomly are in a random distribution, and how the polycystic ones are like a string of pearls in the periphery. So they're not really cysts, they're just eggs. They're sort of stuck and not ovulating. The other thing you may notice is that the stroma of this polycystic ovary is much denser or thicker than it is here in the normal ovary. So when you hear polycystic ovaries, they're looking at the size, the distribution, and these are the other features they're looking at as well. In terms of that morphology, 100% of women with polycystic ovarian syndrome will have the morphology, but also 23% of normal cycling women with no hyperandrogenism, who get their hormones checked every day of their menstrual cycle, they've done studies on this, will have a polycystic morphology. And then it can be present in other disorders as well. Elevated prolactin, late onset congenital adrenal hyperplasia in adolescence. So, that's why it's so important to be really careful about how you're diagnosing polycystic ovarian syndrome. And if you're using the ultrasound as part of the diagnosis, you want to be very cautious how you do that because of these findings. In terms of clinical manifestations, obviously, we want to think about the first two. They're part of the definition, thinking about the irregular cycles or the anovulatory cycles, and also the hyperandrogenism and how are we going to treat those. We also want to think about fertility. Is the patient interested in fertility? How are we going to address that? And then last, the insulin resistance. So in terms of hyperandrogenism, mainstays of treatment include weight loss, cosmetic measures, whether it's laser electrolysis, and hormonal therapy, and specifically birth control pills. And sometimes you may add spironolactone on top of that to help decrease the hair growth and make sure it's thinner, finer as well. In terms of the oligomenorrhea, weight loss can be useful. Hormonal therapy, obviously birth control pills are the mainstay here. Also, sometimes if a patient cannot tolerate birth control pills, we may give a progesterone like medroxyprogesterone or micronized progesterone every 2 months to help shed the lining so that the patients don't get into trouble with endometrial hyperplasia or endometrial cancer down the road. Metformin also can be useful in terms of causing more ovulatory cycles. In terms of infertility, weight loss is very effective. I put metformin here just because I wanted to make sure I didn't forget to mention that metformin really is not a first-line therapy for fertility anymore. Really, we think about a clomiphene or anastrozole as sort of the mainstays for therapy in these patients in terms of ovulation induction, and they can really help patients ovulate and have good fertility outcomes. Sometimes you will see metformin added to try to think about decreasing the chance of ovarian hyperstimulation, but it has been shown in really vigorous studies that really clomiphene and anastrozole are probably the best choices for these patients. Insulin resistance, this is our bread and butter in internal medicine. We think about our diabetics or pre-diabetics, how we actually treat them, and it's the same in these patients. You think about weight loss, exercise, metformin if they have evidence of insulin resistance or acanthosis on exam, and you want to monitor their blood pressures and lipids very carefully. So in summary, we spoke about 3 cases today, 2 very common in primary care and endocrinology practice, 1 less common but with important management implications. We spoke about hypothalamic amenorrhea and how making the diagnosis in terms of the history, thinking about people with amenorrhea who are maybe excessive exercisers or have lost a tremendous amount of weight or in a stressful state, either physically or psychologically. We thought about which labs we would order, the 4 labs that we'd like to order when we evaluate amenorrhea, thinking about the prolactin, TSH, FSH, and pregnancy test, plus minus estradiol if you wish. We thought about management. Most of these patients do not need an MRI. You do want to consider bone density in these patients if they're greater than 6 months without menstrual cycles. Treatment, weight gain, hormone replacement therapy, or birth control pills. For primary ovarian insufficiency, we talked about the definition, absence of menses or really rare menses, less than 40 years of age, you check twice. The diagnostic evaluation, karyotype, Fragile X, consider those, and treatments, OCPs and hormone replacement. And last, we talked about PCOS, extremely common. We talked about the Rotterdam, which is the definition we use nowadays, the clinical manifestations, and how the main treatment options for most patients are birth control pills plus spironolactone if needed. And then we also consider metformin and obviously weight loss for all patients as well. And with that, I'm going to go ahead and start with my first question. A 24-year-old woman comes with a 6-month history of amenorrhea. Her thyroid review systems are negative. She has no hot flushes, night sweats, or galactorrhea. She's on no medications. Her physical exam is unremarkable. Her HCG is negative. Her FSH and TSH are normal. And her prolactin is slightly elevated at 30. Normal's up to 18. And you confirm this on repeat evaluation. So what is the next best step? Do you treat with bromocriptine, cabergoline, treat with an oral contraceptive, give a progesterone challenge, obtain a pituitary MRI, or repeat the prolactin in 3 months and no treatment for now? I'll give you So it looks like most people. So it looks like most people think obtaining a pituitary MRI is the next best step. And that is correct. I don't know if I can move to the next. Let me try. Oh, there it is. Good. Yeah, so definitely obtaining a pituitary MRI is the next best step. As we described, even a mild elevation in prolactin has to be investigated because we worry in someone like this with hypothalamic amenorrhea and a mild elevation prolactin, whether it's a large pituitary adenoma causing stalk deviation, and that's why we're seeing this. We wouldn't start treating with bromocriptine, cabergoline until we figure out do they have a prolactinoma. An oral contraceptive really wouldn't get to the etiology. The progesterone challenge really wouldn't get down to why is the prolactin high. And I would say you've already double checked it, so no reason to wait another 3 months. Good, so we'll go on to the next question. We have a 34-year-old woman with a 4-month history of amenorrhea who comes to see you for evaluation. Her menses had occurred every 2 months before they stopped, and her exercise routine is unchanged. She runs about 25 miles a week. She has no hot flushes, no night sweats. Her thyroid review systems are negative. Her physical exam reveals some terminal hair growth of her face. Her TSH, FSH, and prolactin are normal. Her HCG is negative. So what would you do next? A medroxyprogesterone challenge, treat with OCPs, treat with metformin, an MRI of the pituitary gland, or a pelvic ultrasound? I think we're getting good consensus here. So, it looks like about 57% think medroxyprogesterone challenge, and then about 26% think pelvic ultrasound, and then some people OCPs or metformin. So the correct answer is a medroxyprogesterone challenge. And the reason why is that it's in this patient, it's unclear whether this patient could have a PCOS or hypothalamic amenorrhea. When you have features of both, I find the medroxyprogesterone challenge extremely useful. So you can imagine if someone is more hypothalamic amenorrhea, you give them a medroxyprogesterone challenge, they will have no withdrawal bleed because of the low estrogen state. If someone's more PCOS, their estrogen levels are fine. They just are not ovulating normally. So when you give a medroxyprogesterone challenge, it will cause a withdrawal bleed. So this is where this can be very useful as well. In terms of the pelvic ultrasound, I just want to address, because I know that about 30% of people thought that was the right answer. I think that would not help us, because even if you saw, say, polycystic ovaries, we know that 25% of women who are normally cycling. This woman's not normally cycling, but in other disorders, people can also have polycystic ovaries. So I don't think quite yet I would jump to that. I would first try to figure out, is it low estrogen or higher estrogen or normal estrogen state from that perspective. And that was my last slide. I have some references here that hopefully you'll find useful around these three diagnoses. Thank you for your attention.
Thank you so much, Dr. Yielamis. There were a number of questions. You were very clear. We're going to save those for our question and answer session. And really, that was such a terrific overview of these really common menstrual irregularities that we see in our female patients. Thank you again.
Thank you so much, Dr. Rexroad.